supraannular is smaller than the annulus or the LVOT, then you would need to be careful because you may have to downsize the valve. Now, if this is the condition, then you need to look at the intercommissural distance, and if the intercommissural distance is good, then you can even go for the larger valve. Now, these are the recommendations that I discussed in a while. Measure at 0.358 millimeter. If tubular, size based on the annulus and implant normally. If tapered, size based on 5 millimeter, implant shallow. Be aggressive with pre-dilatation. If you are not aggressive with pre-dilatation, these are the valves which are very fibrotic, either very fibrotic or very calcified. And if you are not going to pre-dilate, you may land into problem. The second thing is, it also depends upon which of the two leaflets are fused. If it is a R and N fusion, please expect that you may have more problem than L and R fusion. So if it is a R and N fusion, pre-dilatation is a must. Despite all these things, we always say that you need to pre-dilate all the bicuspid aortic valve. At the end of the procedure, if you have a gradient more than 12 millimeter, then always post-dilate that valve. If you have a PVL that is greater than mild, then you need to post-dilate that valve. There is another reason why you need to post-dilate these valves. Now, suppose you implanted this valve. The valve is not opened well in one of the dimensions, but your gradient is fine and there is no leak. If you leave these patients just like that, these patients will come back after 5 years and with degeneration of the valve. So what you need to do is optimize the valve so that the degeneration can be stopped. As you can see, there is no definite guidelines for sizing a bicuspid valve. It is all depends upon the experience of the person. This is the last trial that came comparing bicuspid aortic valve with tricuspid aortic valve in low risk population, and this was done with Medtronic valve. You can see the baseline characteristic is almost same in both the categories. However, in a bicuspid aortic valve, more pre-dilatation was done than in the tricuspid aortic valve. You can also see that the use of embolic protection device was higher in a bicuspid aortic valve than in a tricuspid aortic valve. And the chance of recapture of sheath, this is a Medtronic device, so you can recapture and redeploy. So the chance of recapture was higher in the case of bicuspid aortic valve than in a tricuspid aortic valve. The device success rate was similar in both the cases, and the rate of pacemaker was also similar in both the cases. The outcome was almost same in both the cases, and so was the hemodynamics. The valve gradient as well as the valve area was similar in both the cases. The PVL rate was similar in both the cases, and that is why nowadays we don't exclude bicuspid aortic valve for TAVI. We go ahead and just do the case. And I can tell you, you need extra precautions while doing the cases. So I'll just show you a couple of cases so that you can understand how to tackle these kind of cases. This was a type 0 bicuspid aortic valve. You can see there is no raphe at all. There is a calcium in the annulus. That calcium runs into the LVOT. It also goes above in the sinus. So we did the aggressive pre-dilatation. You can see the calcium is confined to one, that is NCC, as well as in the RCC region. Did an aggressive pre-dilatation. Now, the reason for aggressive pre-dilatation in these valves is, in these cases are, if you do aggressive pre-dilatation, maybe you may not require a post-dilatation. We deployed the valve in this case, and you can see there is hardly any leak, and post deployment of the valve seated very well. This is another case. This is a type 1 bicuspid aortic valve. You can see this raphe over here. This is again heavily calcified valve at the annulus, and it also runs somewhat in the sinus of vessel valve, but it doesn't go into the LVOT. As I told, most of these cases you will have either horizontal aorta or the leaflet may be so large that there may be chance of coronary closure in these cases. So you should be very careful. And if you see that the leaflet is very large, you need to measure the length of the leaflet. Now, if the measurement of the length of the leaflet is more than the height of the coronary, there is chance of coronary closure. And in that cases, you need to do coronary protection so that you don't end up with coronary closure in these cases. Now, you can see the aortoventricular angle is 61° in this case, telling us that this is a very horizontal aorta. You can see from this video that the aorta is very horizontal. We again pre-dilated this valve and implanted the valve. This is again a Medtronic valve, and you can see it very good result without any leak. The gradient was less than 10 in this case. This patient has done quite well. This is the third case. You can again see that this case, there is hardly any amount of calcium on the valve except some SOV, there is some calcium. There was a spikes of calcium on this. But if you see this valve has this thickening, this dark thickening you can see, as well as the thickening over here. This is fibrosis on the leaflet. And if you are not going to pre-dilate this valve, you will end up in problem because it will be very difficult to post-dilate this valve. So you start with pre-dilatation. After pre-dilating, you implant the valve, and then you post-dilate the valve. You can see there is a small leak over there. Now, the reason for this leak, I'll just explain it to you, why this leak can happen, and you should not be so aggressive in post-dilatation in these cases. This opening of the valve will be something like this. So when you implant the circular valve, the leak can occur from this side and the other side. So if you are too aggressive in post-dilating these valves, then you end up with an annular rupture. So if you get a small amount of leak, just accept and move forward. This is another case, a heavily calcified valve, and you can see again the angle is something like 74°. This is a very horizontal aorta. There is the calcium that runs into the LVOT as well as in the sinus of Veselva. We pre-dilated this valve very well, and then we implanted a balloon expandable valve in this case. This was entirely because of the economic reason of the patient. However, after implanting the balloon expandable valve, you can see there is hardly any leak, but you can also see that the valve has actually been deployed at almost 0 position. This patient did quite well. This is another case. You can see it's again a type 1 bicuspid aortic valve, very heavily calcified valve on the annulus as well as it goes into the LVOT. The angle again here is 67°. So it is a very horizontal aorta again. Now in this case, it was easy to cross the valve, but when we wanted to, push the balloon would not go. So what we did is, instead of using a safari wire, we upgraded to a Lunderquist wire. After upgrading to a Lunderquist wire, we ballooned the valve. After ballooning the valve, also the valve would not go in. This valve was a right and non-cusp fusion. So when you have a right and non-cusp fusion, what happens is this SOV becomes larger than the upper one. And whenever you try to push the valve, it goes and strikes on the top portion. So you need to realign the valve. And to realign the valve, what we did is we used a snare so that we could realign and push the valve inside. And after that, we deployed the valve. After deploying the valve, you can see that there is some amount of the valve has not expanded well. And if you leave these valves this way, then these valves will then degenerate faster. So we went and we post-dilated this valve. And after post-dilatation, there was no leak, no gradient, as well as the valve attended that circular dimension. And we discharged this patient. It's been, I think, 5 years of this patient. The patient has been doing very well. So to summarize, the presence of bicuspid or tricuspid does not alter the result in the trials. Patient with bicuspid aortic valve requires aggressive pre-dilatation. You may need a post-dilatation or you may not need a post-dilatation. That entirely depends how much recoil is there on the leaflet. Most of the trials shows that more women have bicuspid aortic valve, but that could be just a coincidence. And today, type 0 bicuspid aortic valve is the only one where you should be afraid about some amount of leak. Otherwise, in most of the time in a bicuspid type 1 or type 2, you can implant the valve, be aggressive with a pre-dilatation, post-dilatation, you don't get any kind of leak at the end. Thank you so much. I'll be happy to take any questions.